Good evening, everybody. My name. Can you all hear me?
Yes, I can hear you from Rwanda.
All right, very good. So my name is Dr. Umapathi. I'm the consultant physician and nephrologist from Tanzania. I'm also the medical director of AHN. So on behalf of my colleagues from Tanzania, I would like to welcome you all into today's nephrology educational webinar. And today I'll be moderating this conference, our meeting with Dr. Pascal Rugajo, who is of course my teacher as well. He's the head of department internal medicine at Muhimbili University College, and also the head of nephrology at Muhimbili University. I'll also be with Dr. Jonathan Wala, who is a consultant physician and nephrologist at Aga Khan Teaching Hospital in Nairobi, Kenya. Together, we'll be moderating this webinar. So our topic today is the use of oral hypoglycemic agents in chronic kidney disease. But before I invite the speaker, I would like to invite Dr. Rugajo to give us a little bit highlight and invite Dr. Umapathi, who will be our speaker. Dr. Rugajo, please.
Okay, thank you so much, Dr. Makwabe. Thank you, AHN. Thank you, Nikhil and Lloyd, and all of you. In Tanzania, at least, good evening, everyone.
Good evening.
Thank you. So actually, I've been looking forward for this talk. It is very exciting. It is very clinical-oriented talk. And as nephrologists, we know that diabetic kidney disease is at least a leading cause of CKD in the West. And although data is still scanty, but we still feel it reflects the picture here as well. We know that diabetes affects both metabolically and hemodynamically the progression of kidney disease. And there is emerging evidence of podocyte injury with diabetes mellitus. As a nephrologist, I would be very interested in the choice of oral hypoglycemic agents for my patients with declining renal function. Every time I want to choose a specific oral hypoglycemic drug, I wonder, can I use it in low GFR? Can I reduce the risk of hypoglycemia? Can this drug offer renal protection? Can it retard the progression of CKD? And indeed, can it reduce or retard fibrosis? So the choice of oral hypoglycemic drug is a clinical decision to be made, and at times very tricky. But again, we know that with declining kidney function, there is also an element of burnt out diabetes, and patients tend to be either euglycemic and at times hypoglycemic. So it would be very interesting to hear from the expert on what should be guiding the nephrologist on a choice of oral hypoglycemic drugs, especially in the background of declining renal function. So I have utmost pleasure and privilege to introduce to you Dr. Umapathi Hegde, MBBS, MD, DNB from India. He's a consultant nephrologist at Muljibhai Patel in Nadiad in Gujarat, India. His area of practice includes renal transplantation, general nephrology, maintenance hemodialysis, and all types of CRLTs, as well as renal angiographies. He spent his fellowship under International Society of Nephrology in the University of Arkansas, USA. He teaches DNB nephrology fellows. In the publications world, he has published over 90 publications in peer-reviewed journals. He has contributed 18 book chapters in several books, and he has been involved in more than 15 clinical trials. He's a member of Indian Society of Nephrology, International Society of Nephrology, and American Society of Nephrology. So it is my utmost pleasure and privilege to welcome Dr. Umapathi to take us through use of oral hypoglycemics agents in CKD. Dr. Umapathi, the floor is yours.
Thank you, Pascal. Thank you, the AHN, and I really thank Dr. Vincent, Amar, and Nikhil, and all the members for giving this opportunity. And thank you very much. And I hope it will be useful. And so we all, know that diabetic is a pandemic disease, and it is increasing everywhere, even our country, and the same thing is in your country also. Almost around 35% of the kidney disease is because of diabetes. So I'm going to have the talk on whatever the glycemic issues and the oral hypoglycemic agent, what we have, and the benefits and when to stop these things. So diabetic is pandemic disease and is more common cause of chronic kidney disease, almost to the tune of around 35% to 40% in our registry what we had. And it is on most often things, all the diabetic kidney disease, they don't progress to ESRD. All these patients wither away because of the cardiovascular events, because there is an endothelial dysfunction, accelerated atherosclerosis, and most often heart attacks. So better control of glycemia, early diagnosis, along with that, the blood pressure control, you'll be able to reduce the progression of kidney disease and reduce the complications problems. So you all know that there is a prevalent diabetic leads to all complications, the macrovascular complication and also the microvascular complications. Among macrovascular, you have coronary artery disease, peripheral vascular disease, which is almost to a tune of around 21% and also around 8 to 10%, which increases with the uncontrolled hypertension and the smoking and everything. The nephropathy, if you see almost around 25% or 26% will have nephropathy, and neuropathy and retinopathy is also a part and parcel. And usually we go by the retinopathy and the nephropathy go hands in hand. And so we usually, if there is no retinopathy, we think that there is no diabetic nephropathy, and maybe do a biopsy, and if there is no other compelling indications. So usually we know that the diabetes is a chronic risk factor for cardiovascular events, both even if it is compared to normal or an impaired fasting, impaired glucose tolerance, or a diabetes. If you see that the survival is significantly poor in those who have diabetes, and even in those who have impaired glucose tolerance. So not only the diabetes, even impaired glucose tolerance also leads to decreased survival. The same thing is true in those who have normal as compared to the diabetes, and impaired fasting. If you have also, it's almost slightly inferior but not significant, but you have a diabetes, significantly reduces survival. We all know that the early reduction in the HbA1c reduces the deaths, heart attacks, microvascular complications, and the peripheral vascular disease significantly from the UKPGS studies, which we all know. The glycemic related issues in diabetes is because they may have both. Some patients may have hyperglycemia, some may have hypoglycemia. As Dr. Pascal already said, there will be a burnt out diabetes in almost 30% of the patients with diabetes as the kidney function goes down from stage 3 to stage 4 and down. Increased risk of hyperglycemia is because of the increased production and also the use of glucose, and increased disposal, and there is more and more insulin resistance which is there, and this all lead to increased hyperglycemia. Increased risk of hypoglycemia is because of the decreased food intake, impaired renal gluconeogenesis. Almost around 20% of the sugar is generated by the kidney. So kidney is an important organ for gluconeogenesis, which increases the sugar in a normal state. And there is an insulin clearance, which is reduced by the kidney as the GFR goes down, and the oral hypoglycemic agent also reduces. The monitoring is a problem because what we usually measure, the HbA1c, is falsely elevated by around 0.5 to 0.75 because of the carbamylation of the erythrocytes and because of increased uremic toxins. And the metabolic acidosis also increases the early change of increasing rate of carbamylation, or also the glycosylation of the HbA1c. Falsely decreased is because of the increased turnover, the lifespan of the RBCs is less, and the use of erythropoietin, more and more younger RBCs that come into the picture. So there will be more, and so there is no sufficient time for glycosylation. So reduced lifespan reduces the HbA1c, the metabolic acidosis, which increases the HbA1c, and the altered dynamics and anemia, blood transfusion, erythropoietin, all will lead to reduction in the HbA1c, but the analytical interference with uremia, carbamylation, all will increase the HbA1c. So there are both factors which increase the HbA1c and reduce the HbA1c, also both play an important role in chronic kidney disease. Again, there is an effect of drugs. Whatever drugs are used, the metabolism is changed, pharmacokinetics has been changed. The absorption of the drug also altered because of the gastroparesis, and there is a use of antacids or intestinal CYP450 activities reduces, especially in phase 2 or in a 3 and 4. So, and the polypharmacy, what we use, carb calcium binders and other phosphate binders, they also interfere with an absorption. Distribution also hampers. Hypoalbuminemia is the most important factor because the most of the drugs are bound to it. So if there is a hypoalbuminemia, the free fraction goes on increasing and the bound fraction reduces. The hypoalbuminemia alteration in the protein binding and also the volume depletion, that it depends on whether it's a fat soluble or a water soluble drug. Changes in the body composition of the muscle wasting leads to decreased disposition, decreased resistance, water retention, edema, all will lead to dilution of the drug. Effect of the metabolism, alteration in the biotransformation has been shown in phase 1, phase 2, basically with reduction in the CYP450 activity. So the metabolism is also slower, and the clearance of the drug by the hepatic and also by the renal, if it is excreted, is also lowered. The effect of elimination, as the GFR increases, drugs which are eliminated by the kidney, either by a GFR in the urine, they also gets reduced, they get accumulated, which we can't use it because there will be more and more hypoglycemia. So monitoring of the CKD is an important thing, and we need all the guidelines which have said that the ADA said 7% in a CKD is inappropriate. American Society of Clinical Endoscopy say the best control is 6.5, but the controversy is lower HbA1c, it may reduce microvascular, which has not been shown. The issues in basically in CKD, you need to keep it around 0.5% high. So 7% to 7.5 maybe in a later stages of the CKD, 6.5 to 7 in an early CKD, and in a younger patients. Those who have vascular disease or comorbidity is significant and they have a liver dysfunction, then better is to keep it on the higher side. Self-monitoring of the sugar is the most important thing, to keep the fasting less than 140. 120 to 140 is the better, and the PP2BS less than 7, less than 120 is a better. As the kidney function goes down, and more so in an elderly, you see more and more hypoglycemia. So either with the sulfonylureas and also the insulin. And not only the hyperglycemia, more so the hypoglycemia is also an important factor for increasing morbidity and mortality, because it leads to fractures because of fall, because of the hypoglycemia, it leads to fractures. And also that hypoglycemia per se increases the arrhythmia chances because of the QT prolongation it causes, and the drugs which are already on board, those drugs who are causing QT prolongation, they may further aggravate and lead to arrhythmias. That is the reason possibly the hypoglycemia is more dangerous. We need to reduce the episodes of hypoglycemia. So the goals in diabetic management is, the first is HbA1c control, the upper normal, and the fasting should be controlled, PP2BS, blood pressure control, and the lipid control. All these will lead to a comprehensive reduction in the complications of diabetes in the kidney and also the other vascular complications. This is an octane. So now it has become a decade also, basically different mechanisms of hyperglycemia. One is adipose tissue disposal, and also the impaired sugar excretion, and the gut absorption is increased, and the muscle disposition, and the liver increased hepatic gluconeogenesis, and the reduction in the urinary excretion. They're all the different mechanisms by which the hyperglycemia is caused. So the different drugs, the pioglitazone and the rosiglitazone act on the adipose tissue and the PPR gamma activation, sulfonylureas and replicant acts on the pancreas to increase the insulin secretion, acarbose acts on the gut to reduce the absorption, and the rosiglitazone, pioglitazone, metformin act on the muscle also to increase the uptake and sensitization. Metformin and pioglitazone act on the liver, and also the other, the SGLT act on the kidneys, and the DPP4s act on the gut. So these are all the different drugs at different sites. Then we come to the different classes which we can use in different stages. And the sulfonylureas are the major and the cheaper drugs, but we have now moved to the second generation and the third generation, tolbutamide, clopropamide. They're all almost not used nowadays, or very, very sparingly used in some. The second generation are still used. Glibenclamide you use, but because it's a very potent drug. Glipizide and the glycoside, they are also can be used in CKD patients. The glimepiride, it can be used in stage 1 and stage 2 CKD, and stage 4 and 5, you need to reduce the dose to prevent complications. So effectively, more commonly nowadays, the glimepiride is used, and the glipizide and glycoside may be used in CKD patients. How it acts? It acts basically by the glutamate receptors. When it combines, it increases the potassium release and glucokinase ATP generation, and acting on the potassium act on the sulfonylurea receptor. Sulfonylureas receptor is acted both on sulfonylureas, and also the replicant also acts in the similar manner. So the potassium entry, it causes depolarization, and it leads to opening of the calcium, and calcium will lead to acting on the myosin filaments and releases the insulin. So you all know this. So, and the different levels, the class 1 or the 1, basically you can't use because no adjustment it should be avoided. And the glipizide don't require any adjustment in stage 1 to stage 5. Glipizide should be reduced and titrated to prevent hypoglycemia. Glyburide should be avoided, and the glimepiride can be used almost to stage 4 CKD, but it should be avoided because increasing chances of hypoglycemia. Sulfonylureas, they have strongly protein-bound drugs, and efficiently, if there is any hypoglycemia because of the sulfonylurea, if you do dialysis, it can be, it is not removed. So you have to wait for it to get removed. Glibenclamide has its metabolites which are excreted in the urine and gets accumulated in the urine. Glipizide, glibenclamide may have an inactive metabolites which are active, which may also lead to complications of hypoglycemia. Glimepiride metabolisms in the liver, and it's a 5 to 8 hours of half-life, and 60% dose which appears in the urine. So hence, as in the CKD4 and more so in the CKD5, you can't use it because it gets accumulated in the blood, and it causes hypoglycemia. The most common drugs what we use is, and the first drug to be used possibly, and which has better cardiovascular protection and also the protection of the vascular tree, is the metformin. And it is one of the drugs which reduces the glucose variability and protects the pancreas also. The metformin is around 50 to 60% bioavailable. It reaches Cmax after around 2 to 4 hours. The metabolic action, you all know, it stimulates the hepatic enzyme 5-AMP kinases, which acts as a fluid sensor and increases the glucose conversion to glucose. Primary biological effects is it reduces the hepatic glucose generation and enhances the insulin effects on the muscle and fat, and increases the sensitivity, insulin sensitivity. Kidney is the main excretion, and it is basically by the tubular excretion and the glomerular filtration. Hence, as the kidney function goes down, then you have to reduce and stop when it is less than 30%. So efficacy is it reduces the hepatic glucose production and reduces the HbA1c to the tune of around 1 to 2%, and it causes a small decrease in the LDL cholesterol and triglycerides, so beneficial in cardiovascular protection. No specific effects on the blood pressure, but no weight gain or in weight loss. It is equal. The drugs which are equal on weight are the metformin, DPP4s, sulfonyl, SGLTs. They reduce the weight. So weight neutral, we have to consider whenever we are writing any drug, if they're already an overweight, we have to prefer a drug which don't increase the weight. So this is one of the drug, and the side effects are diarrhea and the nausea, vomiting, and these things. We are worried about the complications of the metformin in later stages of the CKD, especially the lactic acidosis. But the number of episodes of lactic acidosis is much less as it has been documented. So basically, whenever you have a kidney function is very, very less, or any significant organ dysfunction like myocardial function is poor, severe liver disease, and in the presence of an infection and the hypoxia, or when you're giving a contrast, it has to be withheld. Especially by the British guidelines, before the contrast at around 3 to 5 days, you need to stop it, or preferably at least 24 hours you have to stop to prevent the complications of lactic acidosis. How the lactic acidosis occurs due to metformin is because metformin overdose, and it will lead to inhibition of the mitochondrial complex, and which reduce the ATP generation. When you have an ATP is reduced, there will be activation of the AMP kinases, which will compensate for the availability, because there is no ATP production. Oxidative anaerobically, it will lead to stimulation of the glycolysis and lactic acid production from the pyruvate. The stimulation of the fatty acid and beta glucoside also reduces ketones, and it will lead to ketoacidosis and also the lactic acidosis. The production and the excretion is imbalanced because the kidney is not functioning well. That will lead to accumulation and lead to acidosis. So in a nutshell, metformin is a good drug. It is contraindicated when you have renal dysfunction and GFR is less. This is the earliest statement. We will come to that. And it also, the congestive heart failure very much, and the iodinated contrast, it should be reduced. The side effects, in addition to the lactic acidosis, we have, it reduces the formation of B12 in the gut. So B12 deficiency is one of the most common side effect of metformin, and also it increases the histamine intolerance in some because of the production. It reduces the DO. Metformin also reduces the TSH, so the decreases the blood levels of TSH. So we have to be cautious in hypothyroid patients, because most liver disease or any hypoxia, you need to stop, because otherwise you have a high chance of getting lactic acidosis. If the GFR is less than 30, better to stop it and use the other drugs. Metformin has a pleiotropic effect. It has shown to reduce the cardiovascular events. So that's multiple effects are in the obesity. It reduces by lipolysis, thermogenesis increases, and more importantly, microbiome dysbiosis, it reduces. This is also occurring in CKD patients. So using metformin, it may heal the microbial dysbiosis, and it will reduce the generation of toxins, and which will pre-cortisol and other things, which will reduce the atherosclerosis also. Liver disease also will be reduced significantly. Cardiovascular disease are reduced because it reduces the cholesterol transport, and the LDL cholesterol it reduces the oxidative stress and the inflammation. So in the liver and other things, it reduces the gluconeogenesis, and even the muscle, it increases sensitization in the GLUT4, and it will in the intestine, it may increase the GLP and an additive effect with the DPP4s. The aging, the RAS activation, DNA damage, autophagy, all are decreased by metformin, and the renal diseases also, the glucose level, inflammation, oxidative stress, it reduces. Even the cancer has been shown to reduce because it acts on the mTOR. So, and by the mTOR, it increases the autophagy, increases apoptosis. So it's a multifaceted drug, and it has a multiple actions on this, and it has also been shown to reduce the LV mass. And so in a study where it was used with the metformin and the placebo, there was a significant, almost around 5 gram decrease in the LV mass index has been documented. 4.3 LV mass has been documented. In the pre-protocol also, they have shown to be reducing. How it reduces the LV modeling is because the metformin, it reduces the hyperinsulinemia, reduces the gluconeogenesis, and increases the glucose uptake. And the hemodynamic factor, it reduces by the oxidative stress and reduces blood pressure. And the other obesity, it reduces the weight and reduces the adipose tissue genesis of oxidative stress. And all weight reduction, all will lead to the reduced systemic effects, and the vascular effects leads to further reduction in the LV mass. So Even in the UKPS others, people have shown those who are using a metformin, they have a longer life as compared to those who are not using metformin. The other drug which people use in CKD patients is Thiazolidions, basically rosiglitazone and pioglitazone, and it activates the PPR gamma receptor and increases the peripheral utilization of insulin and decreases the hepatic gluconeogenesis. It is highly protein bound and it is bound to albumin, and the rosiglitazone and pioglitazone have almost 3 to 4 hours or 3 to 7 hours of half-life. There is no dose adjustment required when the kidney function goes down, and in hemodialysis does not affect the pharmacokinetic. It can be used in that situation also. There's multiple pleiotropic effects, especially in the metabolic syndrome. The thiazolidions have sustained improvement in the glycemic control and decreases the plasminogen activator inhibitor, and hence it increases the plasmin and also the decreases the clotting. Central obesity, it reduces the inflammatory markers, it reduces, increases the endothelial insulin secretion and reduces the diastolic blood pressure. Microal, because the endothelial dysfunction, which is known as the Steno's hypothesis, when you have reduced the endothelial dysfunction or increased the endothelial function, with one of the representation of microalbuminuria may also reduce. Increases the HDL cholesterol and reduces the small dense NTL, which reduces the cardiovascular events and reduces the insulin resistance. But the problem is the edema along with that. So what all these the pleiotropic effects get translated in the kidney or nephropathy prevention is reduction in the blood pressure is definitely useful, reduces the urine albumin excretion, and the ACR also reduces. Endothelial nitric oxide, which is best for the dilatation and preventing the complications, is also good. And the renal albumin uptake, it reduces, improves the insulin sensitivity, and protects the podocytes and the podocyte depletion, which leads to increased glomerulosclerosis. And it also reduces the extracellular matrix, and the matrix is one of the important factors for production. We all know that there will be more and more matrix production in the glomerulosclerosis, which happens. So the favorable effects is basically the HbA1c reduction, similar glycemic control with, you can use it with sulfonylureas also, reduce the systolic and diastolic blood pressure, and can be used in CAPD, and it reduces the CRP. But the problem is the weight gain, which is an important factor. Most of the people, when you're using thiazolidions, it will have a weight gain of around 2 to 3 kilos, almost to the tune of around 5. And the pedal edema, fluid overload, and the lowering hematocrit may lead to cardiovascular events. But when you have patients who have a heart failure or the LV function is poor, I think this drug should not be used. And especially when you have a large amount of proteinuria and they have an edema, I think we should not use this drug. So the other agents which can be used are secretagogues, especially the repaglinide. So the repaglinide and the sulfonylureas and the netaglinide act in the same receptor of sulfonylurea receptor. So but a different mechanism, it increases the insulin. So the secretion of the pancreatic beta cell is through the beta potassium mediated ATP channel opening, which will lead to increases the calcium and increases the myosin activity and increases the insulin secretion. The HIT is hepatically metabolized, and that is the reason why it can be used in all stages of CKD, and the elimination is almost around 1.8 hours. Less than 10% of the drug appears in the urine. Dosage reductions are not necessary in this class of drugs. It is a rapid short-acting peak. It acts similarly when you use 15 minutes prior to the meal. Repaglinide has a rapid increase, which lasts only for a short duration of only around 3 hours, which coincides with the increase in the sugar post-meal. That is the reason the hypoglycemias are much less when you use repaglinide. The following the oral dose, repaglinide concentration is rapidly increased. It reduces the pre-dose by around 4 to 5 hours. So it's a short duration of the drug. You need to use 2 to 3 times, whichever is required with a lunch or dinner, or even 3 times a day. You can use it with 0.5 milligram to 2 to 3 milligram. You can use it. It is basically metabolized by the CYP450. Even though it is the CYP4 metabolism is reduced, it is not altered much. In all this, it's a biliary excretion. Because of that, it can be used. The most important factor here as compared to sulfonylurea is sulfonylurea also increases the insulin by stimulation of the sulfonyl receptor, but It is different in repaglinide is basically, it increases the release of insulin by the beta cell only in the presence of a glucose of minimum around 5 to 10 millimoles if it is there per liter if it is there. But that is not so in glimepiride or other sulfonylureas. That means in the absence or in a hypoglycemia, if you give it, you don't get even the lower sugar. If you give repaglinide, the action is slightly lower. It won't lead to significant hypoglycemia because increase in the secretion of insulin reduces in the presence of hypoglycemia. So that is the reason it's a beneficial drug. The contraindication is basically diabetic ketoacidosis in type 1, or is there any hypersensitivity to the drug? And even because it is biliary excreted, the liver dysfunction is an important factor. We need to be careful when you are using repaglinide. So the netaglinides are also the another drugs which are sulfonylureas. Similar, it's basically acts to the similar receptor, but it gets eliminated by the hepatic metabolism, but gets accumulated. 83% of the drugs is excreted in the urine, and the primary metabolites are also active. Hence, as the renal kidney function goes down, there will be more and more hypoglycemia chances, so it should not be used in more than stage 2 or stage 3 CKD. So the other drugs which can be used in an early stages of the CKD is alpha glucoside inhibitors. It's a wonderful drug, especially it reduces the weight also and reduces the sudden surge in the sugar after the post meal, and it also reduces the glucose variability. We all know that the variability in the glucose leads to more and more complications, hence there's a wonderful drug to use. The acarbose, it's basically both the acarbose and the miglytol. They blocks the intestinal breakdown of oligosaccharides more into simple sugars, since the absorption is reduced. So the acarbose is minimally absorbed from the GI tract, and at least different metabolites are also there. The miglytol has a greater systemic absorption, so the miglytol is not used in CKD much in a log use. So 50% of the dose is absorbed, so it is renally excreted, almost over 95% is recovered in the urine. So how these acts, when you have a starch and you take it, it's the receptor on the microvilli, and the acarbose acts on the receptor, leads to the breakdown of oligosaccharides. The smaller it is reduced, hence the absorption is reduced. In the post meal, if you see, suddenly there is a surge around 45 minutes to 60 minutes increased in the first hour, and then slowly the sugar comes down. And when you use an acarbose, it is blunted. The peak is blunted because there is no change from oligosaccharides to monosaccharides, and the absorption is reduced. Usual dosage, what we use is 50 milligram 3 times a day. Hypoglycemia, 50% as that of the sulfonylurea and the metformin, so much less, but a major problem is the flatulence is the big problem. If you see, without acarbose, there will be more and more absorption of the carbohydrate, which happens in the first duodenum and the jejunum, much less in the ileum. When you use acarbose, if you see, much absorption is significantly reduced in the jejunum, and very minor absorption happens because the presence of the sugar in the ileum. So glucotoxicity or a postprandial hypoglycemia has also been documented as a significant factor for increased cardiovascular events. All our CKD patients are increased risk of cardiovascular events, and if there is a significant postprandial hyperglycemia, it leads to more and more cardiovascular events. There will be genetic, obesity, and the sedentary lifestyle factors also increase the insulin resistance, and the insulin secretion is an addition to that, they'll cause postprandial hyperglycemia. So it will further increase the hyperinsulinemia and the glucotoxicity on the pancreas, and reduces the further function of the pancreas to increase the insulin secretion, constant hyperglycemia, which will lead to beta cell dysfunction and failure. There was a study which clearly shown when you use an acarbose, there's almost around 64% reduction in the myocardial infarction in these patients. So it is a good drug to use, and it can be used with other combinations also with the metformin, and also with the repaglinide or sulfonylureas it can be used. So the acarbose and miglytol are renally excreted. When we have a creatinine is more than 2, or you can use up to 3 creatinine, you can use it. The basic problem is flatulence, and the diarrhea is a major problem. And if the patient has significant GI intolerance, I think better we should not use it. Now, newer drugs which are there are DPP4 inhibitors, which can be used in CKD different stages, and even on dialysis population. When we take food, take a meal, there will be in a healthy person, there will be increase in the insulin also when you take a food, because there is a glucose it stimulates the pancreatic beta cell to increase the insulin. It suddenly within a peak, as the sugar increases, the insulin also peaks. So at the same time, the glucagon reduces and the glucose, it gets absorbed and it peaks, and the peak coincides with the insulin release. In a diabetic patients, what happens is when you take a food, there is a blunted because the beta cell dysfunction and the insulin release is blunted as compared to the healthy subjects. But the glucagon, it also increases as compared to reduction, which has to happen in normal subjects. So there will be sudden increase in the sugar, which happens not only in 1 hour, even up to 2 hours, it goes up to 4 hours also if you don't treat it well. So in a nutshell, what happens is even on the smell or a sight of the food, it increases the GLP secretion or even the smell or an intake. It will lead to a GLP-1 secretion by the L cells of the intestine. That will lead to a reduction in the gastric emptying and the stimulation of the insulin by glucose dependent fashion, and it will suppresses the glucagon also, and it slows the gastric emptying. So slowly the food gets processed and the absorption is slower, reduces the food intake by emptying and the fullness which will be there because of the gastric emptying is reduced. In a long-term effects, it will have a beta mass preservation, and because it protects the beta cell and it has a more efficiency. And whenever there is a beta cell is preserved, your glucose variability and fluctuation between the severe hypoglycemia is reduced. So after the food intake by the GI, by the L cells, there will be increased GLP and GIP, which are all degraded by the DPP-4s, and by the GLP-1 GIP-4s, they release the insulin from the beta cell, and it will be increased. GLP-1, it increases the glucose uptake by the peripheral tissues, and also the glucagon, it will reduce the hepatic glucose production by acting in two different mechanisms. By increasing the insulin and also reducing glucose, your sugar will be reduced. And DPP-4s are the drug which will act on the destruction of the GLP, which will be the enzyme DPP-4 leads to the destruction of the GLP and GIP, and blocking that enzyme, the activity of the GLP-1 and GIP gets prolonged, hence it has a beneficial effect on long-term sugar reduction. So the concentration of the active hormones are increased by the DPP-4 and it are prolonged, hence there will be more and more insulin release, which will be there. So when you are choosing a drug or any drug, it has to have over 80% of the receptor should be bound to it, then you have an effective action. If not 1 time, you may have to use it 3 times to have a similar effect. So the sita has a 24 hours action. The vidagliptin is, you have to use it 2 times to have things, but I may have a renal dysfunction, then even the drug can have a similar effect or 80% occupancy of the receptor with a single dose. The sita, it's almost around 16 hours has, lina has more than. So all these drugs which have more than 80% of the activity. The monotherapy, basically, it significantly reduces the HbA1c almost to the tune of 0.6 to 0.8 on a long run and over 24 weeks as compared to 0.6 in 18 weeks. As the HbA1c is higher, the reduction is much more, and but you have a very high HbA1c, better to use the SGLT2, which have a more effect. And if you have a lower HbA1c, still the DPP-4s act. But the problem of any agent, what you use, we have a stricter control, is a weight gain. So as sulfonylureas increases the weight gain, this is the weight neutral. If you see the fasting also, it reduces by this, and also the postprandial also reduces. So the reduction is significant. But if you compare to the glycoside and the DPP-4, your lean mass, which will significantly reduces almost to the tune of 2 to 3 kilos, and the hypoglycemia chances are also much less with the DPP-4s, because the sugar should be there for stimulation of the insulin, because the glucose mediated insulin release, which is a mechanism of DPP-4s. So the combination in early stages or even post-transplant we can use is because the beta cell dysfunction, insulin resistance, and hepatic glucose resistance, these are the three cornerstones for the hyperglycemia. Using a gliptin, we are going to block the beta cell dysfunction and the hepatic glucose production. Using metformin, you are taking care of the insulin resistance and the hepatic glucose production. When you use a combination, all the corners of the triangle gets blocked and it will have a more beneficial effect. If you see the different mechanisms of hyperglycemia like insulin production, secretion, glucose, hepatic output, and also the resistance and the alpha defect, incretin effect, all these things, if you see majorly the insulin synthesis, secretion, and the hepatic production are majorly suppressed and also reduces the glucagon effect and the stabilization. Otherwise, there is some effect on the mild effect by the insulin, peripheral insulin resistance reduces and the hepatic resistance also reduces, but no effect on the glucose absorption. So these are the drugs, other drugs which basically act on different things. The sulfonylureas only increase the insulin secretion. SGLT2 only act on the glucose reabsorption, but it is not completely true. It has other beneficial effects. It preserves the pancreatic cell also, and which I'll come to that later. Thiazolidions, it improves the sensitivity both in the insulin in the periphery and also the hepatic. And the metformin reduces the hepatic output, increase sensitivity, and there is some effect on the GLP-1 secretion also. The different drugs which have the cytoglyptin has to be reduced as the kidney function goes down. More than 60 ml, you can use full dose, and you need to reduce it. Vidagliptin, it has to be as 30 to 60 ml, you need to reduce it and you can continue the same. Sitagliptin, it has to be reduced to 2.5 milligram as the kidney function is less than 60 ml. Linagriptin don't requires any dose modification, and the others are basically allogliptin, which of questionable use, you can't use it. So the HbA1c reduction, even though you reduce the dosage, it is not hampered because the duration of action increases. And if you increase or use the same drug, you may not get any significant benefit, or hypoglycemia is also not there. But again, you need not have to use it. The cost efficacy will not be there. So you can use the 50% of the dose when you have a GFR goes down in those like sitagliptin and saxagliptin or vidagliptin. So the reduction in the HbA1c is significant as compared to the placebo, and over 0.5, it reduces the HbA1c. And even in the severe renal failure also, it does the same thing. The beneficial effects in all patients, it has shown to reduce the urinary albumin excretion. So as compared to the baseline 1 year back from the baseline, the almost around 50 a reduction in the UACR, and in the macroalbuminuria also reduced almost to the tune of around 600 to 700 milligrams. The another beneficial effect of DPP-4s is the reduction in the renal fibrosis. Normally, the DPP-4 receptors are separated by the CMMCPR. So the receptor is separated. When you have a hyperglycemia, they can contact, and which stimulates the TGF-beta. You all know TGF-beta stimulation leads to SMART activation and fibrosis. When you use the blockade of DPP-4s, all these drugs, they separate again as the normal glucose control, and they reduce the activation of the TGF-beta, hence it will be reduced. So the glucose increase, it will lead to reduction in the mRNAs and increases the endothelial DPP-4s. You all know that even in the kidney, in the hypoglycemia, DPP-4 expression suddenly increases almost to the tune of around 2 to 3 times. Increases the integrin activation, increases the beta, TGF-beta demineralization, increases the vascular endothelial growth factors, and increases fibrosis. So blocking this, it will reduce the fibrosis. So it will be beneficial. Other beneficial effects of DPP-4 are renal mechanisms, reduces the sodium excretion. It increases by reducing the sodium hydrogen exchanger activity, and the increases the ANP secretion. Stimulation of the sympathetic nervous system is also, it will be reduced, and which all increase the blood pressure is also reduced. So immunologically, it inhibits the T cell activity. So it inhibits the inflammation, and also it inhibits the oxidative stress by elevating the NADPH oxidase and reducing the oxidative stress and red oxidant demand. Insulin resistant mechanisms also reduced significantly. Increase in the substance P it increases the blood pressure, and so the hormonal regulation, the blockade of the AT1 receptor, NH3 expression. So it also has a hormonal mechanism so by reducing the blood pressure. So the blood vessel also, the NO increase also reduces. So multiple mechanisms. So branch 5 DPP4 blockade, and it will lead to increased GLP-1, increases the sodium excretion, tubular reabsorption is reduces, ROS activation of the oxidant stress reduces, inflammatory markers on the lipid proxy reduces the proteinuria, and introduces the fibrosis and glomulosclerosis ultimately, and retards the progression of the disease. So we all know that the reduction in the glycemia and also the albuminuria, it will have a long-term benefit. But as of today, the albuminuria has not been accepted by the FDA as a hard endpoint. It is still a soft endpoint. So we need to go along with that, the hard endpoints as of today. So significant, even in hemodialysis patients, we may be useful, and it significantly reduces the HbA1c as compared to the controls, and the vitagliptin, it reduces even 24 weeks significantly. So the vitagliptin or any gliptin which can be used, like linagriptin also can be used, reduces the HbA1c, and glycated albumin also reduces, and the less hypoglycemia. Even in the new onset of post-transplant diabetes, it also significantly reduces the glucose, and the postprandial sugar also it reduces, and the HbA1c also reduces safely, and it can be used. Even in the people who have heart failure and also the uremia, DPP4 inhibition has shown to increase the GLP, which further improves the LV function and reduction in the heart fibrosis. We all know that the diastolic dysfunction also happens in CKD patients, which are an important factor for sudden LV dysfunction. So DPP4s may further reduce the LV fibrosis and improve the LV function and help our patients. So in a nutshell, the advantages of DPP4 are fasting and postprandial levels of GLP-1 are increased, further reducing the fasting and postprandial sugar, improves the beta cell function and preserves the beta cell function, increases the insulin and pro-insulin and insulin ratio, it increases, and the inhibits the glucagon, insulin sensitivity it increases, reduces the postprandial lipemia, reduces the HbA1c, and it is well tolerated, and renal impaired patients also it can be used. The other drug in fashion, which has gained a lot of importance nowadays, is the SGLT2 inhibitors. So the sugar, it is renally excreted when you have over and above the excretion. When it's filtered, it acts on the tubules, and the SGLT2, it's a major pathway for early proximal tubule, high capacity of absorption to the tune of around 90%. SGLT1 has small capacity, and SGLT2, it has a co-transport with 1 sodium as compared to the SGLT1, which has 2 sodium co-transport. So the drugs which are available, the multiple drugs, I have named only 3. So canagliflozin, DAPA, and EMPA, that can be used when you have a GFR is more than 60. And if it is less than 45, you need to reduce the dose, but again, less than 30, it is not used nowadays. But again, people are still using, the trials are coming, you can still use at 30 ml and even up to the tune of around 25 ml. Even on dialysis patients also, there is a trial which shows that they may prevent the cardiovascular events. We all know that there is a hyperfiltration in diabetes. Normally, the tubuloglomerular feedback, it maintains the glomerular filtration. So whenever there is an decreased sodium, the distal tubule, it senses as there is a volume contraction state and increases the afferent arteriolar. So it will maintain the glomerular filtration rate. In a diabetes, what happens is more and more sugar is excreted, and there is some more and more exchange, the intake which happens. So the more and more absorption of the glucose along with the sugar, which will lead to less sodium delivery to the distal tubule. It senses it as there's a less volume or less sodium. It increases the afferent arterial dilatation. So there will be more and more GFR. When you block the SGLT2, and there will be decreased absorption of the sodium. So more sodium is available, which goes to the distal tubule and gets excreted also. And this more sodium in the distal tubule, it contracts the afferent arteriole, reduces the hyperfiltration. Hence, one of the mechanisms of diabetic dysfunction or progression of the kidney disease is hyperfiltration, which will be reduced. So you all know that then there's a hyperfiltration when you use any of the DAPA, EMPA, or so there will be a reduction in the GFR in the first 2 weeks to 4 weeks. it is almost to the tune of around 5 ml or 4 ml when you use 5 milligram or 10 milligram. And as the time passes, it increases, or the deterioration of the GFR goes down as compared to the placebo. You see a better preservation of the kidney function. So the benefits are basically hyperglycemia leads to, there will be an overgrowth of the proximal tubule, and there is more and more absorption of the sodium and also the glucose because of the increased, there will be increase in the SGLT2 expression. And the more absorption of the sodium goes less to the distal tubule, and it will increase the single nephron GFR. And the glomerulus also, hyperglycemia increases the angiotensin A and angiotensin II. It will all lead to increase interglomerular pressure, increases the albumin excretion. In the proximal tubule also, it leads to increases the angiotensin, will lead to increased tubular reabsorption of sodium, and water salt increases the blood pressure. All this increased blood pressure and single nephron GFR and albuminuria will lead to the overstress and increases the progression. Or blocking by the SGLT2, it reduces the albuminuria, and also single nephron GFR reduces, and even sodium is get excreted more, and the volume expansion also reduces. So the inhibition of SGLT2, it also reduces the hypoxia and increases the erythropoietin production. You all know that the diabetics will have less and less hemoglobin, and it is possibly that erythropoietin levels are less. So decreased sodium reabsorption, decreased metabolic demand which happens, and the increased sodium delivery and increased contraction, which will lead to preservation of the kidney and the GFR. And the decreased blood flow also is there and senses it. So there is increased beta hydroxybutyrate, which increases the sensitivity of to increase the erythropoiesis. So SGLT2s, all they have beneficial effects, and causing a vasoconstriction, it increases the tubular blood flow also. And there will be more and more erythropoietin, which is reduced, which increases the hemoglobin, which will is better for the heart and also the erythrogenesis and also the brain, and the inflammation also reduces because the hypoxia is an important factor for increasing the inflammation. So the oxidative stress decreased fibrosis and induction, and the inflammation, tubular senescence, and the glomerular damage is reduced by the SGLT2. Even the weight reduction, amelioration of the volume and the blood pressure will protect the heart and reduce the LV mass index and increases the oxygen delivery, and the cardiac function also it improves. Why? How the erythropoietin production is involved? Because there is a proximal tubule, because of the overburden of the glucose, there is conversion of the fibroblasts to the tubular cells. So there will be decreased synthesis of erythropoietin. Whenever there is a euglycemia is achieved, cortical interstitial damage also recovers, erythropoietin production is also restored by the fibroblasts, and hence you get more hemoglobin. And it also reduces the uric acid. It is also, but again, there's a little bit of controversy is there. Uric acid is also protective. It's a cardioprotection by reducing the uric acid, and also the renal protection. The mechanisms are multiple by decreasing NADPH, blood pressure, fibrosis, and other things. It basically by excretion of the MRP4, and so it will increase the uric acid excretion, and hence it will be more and more useful. The EMPIREC trial has significantly shown that use of, as compared to the placebo, it significantly reduced the albumin excretion, and the retardation of the GFR, or reduction in the GFR, is also reduced. Even in the 80 ml, it also significantly, and even those who have 70 ml GFR or less than 60 ml GFR, also there will be reduced GFR reduction. So in all other, and the microalbuminuria also significantly reduces. I am not showing the other trials which also significantly showed benefits in proteinuria reduction, and the slope of the GFR is significantly reduced. So in an EMPIREC trial, almost 18 as compared to the 18% in a placebo progressed as compared to 12% regression. So overall 39% relative risk reduction was seen, which is a very significant factor on reduction of the progression. And even it has shown the progression to macroalbuminuria also reduced by 38%, which is very, very significant. In a nutshell, SGLT2s have a direct cardiac effect, metabolic responses, osmotic diuresis and natriuresis, and the direct renal effects. Direct renal effects, you all just saw that the albumin excretion, pressure in the glomerulus, inflammation, and NH3 activity. It preserves and reduces the albuminuria, worsening nephropathy, and protects the heart. Osmotic diuretic increases erythropoietin, increases the hemoglobin, and also the decrease in the plasma volume, blood pressure. It increases the cardiac efficiency. Metabolically, it increases glucagon, and also it increases the glycosuria, insulin resistance. It reduces, and the weight it reduces. As the weight reduces, the insulin sensitivity is also increased. Direct effect is also there. So all will lead to cardioprotection and the renal protection. The benefits, again, which I just alluded to, the risks, basically every drug has a risk. So genitourinary infections were almost to the tune of around 5 to 8%. But as of today, people have said that if there is a minor infection, you can reduce the dose, temporarily use the antibiotic and the antifungals, and you can get away with it. Increased ketosis is one of the important thing in a normal sugar ketosis, and the increased AKI, but it is not so, which I'm not showing because of the scarcity of time. In a comparative trial, which I've shown, because all these drugs, which have multiple mechanisms and renal protection, the AKI is much less. Amputation chances also reduced. The hypotension is much less. To summarize, the diabetes, again, you have to diagnose early. Urine excretion of the protein and the serum creatinine calculation of the GFR is an important, because all drugs which are used in CKD has to be monitored. The HbA1c and the sugar has to be monitored. Insulin is one of the best drugs to use it, but oral hypoglycemics also can be used. We have to titrate it and to use the drug accordingly. Blood pressure, ACE inhibitor, ARBs is best, and the hyperlipidemia also has to be taken care of. And the nutrition is an important factor, reducing the sodium intake and the potassium moderation, and reducing the phosphate is also help. Anemia management important has to be there. In a nutshell, to last, the first generation should be avoided in dialysis patient and the CKD patients, those who have less than 70 ml of GFR. The second generation, glipizide, no dose adjustment required. Glyburide should be avoided in stage 3 onwards. Glimepiride should be avoided in dialysis or in the stage 5 CKD. Alpha glucose inhibitors, it should be avoided in 2 or 3 milligram of creatinine, and metformin should be reduced if less than 45 ml GFR and stopped when you have a GFR less than 30. Pioglitazone and reticulazone, no dose adjustment required, but it has to be cautious when you're using in a patient with an LV dysfunction or an edematous patient, because you may precipitate congestive heart failure. Repaglide, no dose adjustment. Netaglinide should be avoided in more than 3 stages of CKD. Incretin can be used, and again, a DPP-4's different drugs are available. It can be used with dose modification. SGLT2 can be used up to 30 ml of GFR, and now where trials are coming up even in less GFR. So summarize, diabetic is common. Different OHAs have different mechanisms of action. The combination maybe have beneficial. Worsen kidney function, we need to adjust or stop the oral hypoglycemic agents, and hence we need to have a good follow-up every 3 monthly when the kidney function goes down. We need to choose the OHA according to the mechanisms and accumulation of the drug, case by case, considering the benefits and the risks. Third generation sulfonylurea, repaglide, DPP-4 inhibitors can be used even in the late CKD. SGLT2 have a promising drug, reducing the progression and in the recent trials, and it can be used in mild to moderate CKD also. Thank you very much. We are still fighting with diabetes, which is an important thing, but their efforts are much still less. Thank you very much.
All right, that's very exciting and interesting presentation from Dr. Hegde Umapathi. Thank you very much, Dr. Hegde. Really appreciate your presentation.